So the title of this was Academic Opportunities, but that sounds really scary, doesn't it? So let's start saying, what do you mean by academic? So you can say, well, it's an institution like the Norwich Medical School or the Wellcome, a qualification, an activity, something academic you do, a systematic review or research project or a QI initiative or whatever, quality improvement that means. And I think, to me, it's an approach. It's actually that bit where you kind of step back, you think about what's the issue, you do some analysis, perhaps using evidence or, data or whatever. It's a objectivity. And that's why I think academic aspects of general practice matter for every GP or every doctor, or in fact, in lots of human beings. It is somehow used, though, sometimes as a derogatory term. Oh, don't be so academic. That kind of means you're somewhere else in your head. I've never understood it, but I've heard it said often in meetings, oh, that's just academic stuff. So, there's a debate about the way in which we embrace academic aspects of our jobs. And you may think of other things as well. In terms of choosing a career in general practice and where this fits in, of course, people undertake formal qualifications. So some of you may have already done intercalated degrees. Everybody's got to do the membership exam. And then a lot of people sooner or later do something, a postgraduate certificate or some other diploma. If you have special interests, you sometimes take a qualification in that area to show your additional competencies and so on. As I already implied, I think a lot of where we use an academic interface is when we're employing evidence and looking at practice and how to improve it. So, whether it's an audit project or, thinking of telephone access, a lot of patients are complaining about what's actually going on there. Let's collect some data. Let's get some insights from that. Let's look at the stories that are coming in. Let's look at the hundreds of people who aren't complaining. It's that sort of stepping back. And also many practices host research. So I'm an academic. I rely on our GP practice network to recruit patients or indeed to recruit staff to studies. And we have about, in our patch, at least 40% of the practices routinely signed up to the research network. And then some of them will join as they're approached about new studies. And that's really important because that's where the work is going on. And we can't get to community settings unless practices help us to do that research. So that's another interface for the normal practice team. And then some people take up academic careers as a special interest. I'll talk a little bit more about that. Some people start to get more involved with the academic side as they take up extended practice roles. So I've got colleagues who've done a diploma or even a master's in business because they actually want to understand the business side of things and the theory behind running a good business or commissioning services and all those things. As you develop roles, sometimes people think, right, I'm going to do a bit of training in that because I want to deepen my understanding. Local leadership positions. Many GPs take up educator roles, whether that's with undergraduates or postgraduates or both, and sometimes additionally to assist colleagues as CPD, continuing professional development leads. And we have many people who interface with the college to help us to develop our different modules for members, working sometimes with other colleges or special interest groups. And that's, again, a role that quite a lot of GPs get into sooner or later. And incidentally, you may say, well, is there a career structure for that? Because I can see the GP trainer one and how you get into that. And I can see how our local medical school uses GPs as teachers, whether it be for placement or on campus. But I can't understand the CPD thing. In the old days, most patches had a CPD tutor. I had that role in Sheffield for quite a long time. At the moment, it's kind of disappeared a bit, but it may reappear or be hiding under the umbrella of HEE, and people like Margaret who work in that field can kind of keep us up to date. So those roles change over our career lifetimes, but they're always there, and that's another part of it. And then if you get hooked onto it, and I'll tell you about my story in due course, you actually can also be employed as an academic in a university, lecturer level or above, There are different contracts for GPs who act as teachers, so I'm not talking about that there. I'm talking about people who have an academic career as well as being a GP, where we're leading teaching and research. And this is the making the mark bit. You know, there's also an academic aspect to political leadership and advocacy. So to be a college officer, it is not essential to be an academic. Some of us are, Martin, for example. Many aren't. But the point is that you've got to have the evidence at your fingertips, and you've got to be good at explaining it smartly and succinctly, which is the advocacy skills. And whether that's in a meeting with, you know, other parts of the health service, you know, you've heard about maybe integrated care systems, you know, if you're a GP lead in that and you're trying to persuade people from the hospital that something needs to change, you've got to know why, know what the difference is, what the intervention is, why you think that's going to be effective, and you've got to be able to put it across smartly. So all the leadership roles, including ones in a sense that maybe aren't about general practice, but as citizens, we're often also advocating for our community, resources, and so on. And those skills are in the sense of being analytic, objective, and smart, having the evidence at your fingertips. That's an academic skill as well. And sometimes there are things that interface with our non-GP priorities, although again, I won't put that up for completeness really. But being analytic about why your grandchildren misbehave and what they're angry about, actually quite important sometimes, helps you step back. So things that might influence your career choice. I think that's the point of having the workshop, isn't it? So I think who you are and what matters to you and the opportunities that are available to you are things that influence our careers and the way they go, and Claire and Margaret have already given us some insights into that over time. Early impressions and experiences matter quite a lot. So for us as a college, that's where the debate comes about the visibility of GPs in medical schools. You know, do you see GPs? And if you do, are they seen as the same status as the other teachers? Do you have an academic professor? Does she come and teach you? Do you see people around the medical school, or are they all professors of biomedicine? So I think what gets into our head early on about academic work and whether it's good, high status, smart, or whether it's a bit, you know, too academic, actually also does influence whether people choose it or not. And then similarly, whenever the academics come in and teach the students are thinking, oh God, how tedious was that? You know, that's not going to really persuade people that that's an interesting way to earn a living. So all those early impression things. And then of course, what actually happens as you go through, and again, status and image, but also salary and working conditions. So this is interesting. There's been a big debate, you know, over the university sector about the fact that clinicians can earn a lot more in full-time practice than they can if they take a part-time university role, and how you even that up, and how that, you know, actually still people, you know, choose that anyway. And that's quite a political thing, which I won't dwell on at your stage, but I think sometimes people are persuaded or dissuaded from different career choices by whether they're going to lose income or whether they're going to have a steady income over time. And, you know, all those salary and conditions things do influence the choices that we make in our lives. The other thing, and this is a broad list, but it's about flexibility, and it's about, you know, doing things at different times. And I was saying to a colleague earlier over the coffee that, you know, you don't have to do it all at once. Sometimes you'd make one choice early in your career. Let me just get on with being a GP, put it under the table, you know, get used to doing the clinical work, get used to being in a practice, get used perhaps to running a practice, but then later I'll take on an additional role when, you know, then that keeps you stimulated, and that's actually what happened for me. And the other things that I think influence you is then who you're interacting with. So several points in my career, people have come to me and said, oh, Amanda, there's, this job's going, and I thought it's something you might be interested in or you might be good at. And the college, again, your local network through the college, peer groups, learning support, tutors, all those things can help you test things out, find out what's involved, but also perhaps get in through that door. And then, of course, sometimes it's also about, is there an opportunity? So we're seeing, for example, a lot of emergent training fellowships for GPs early in their careers, and that's giving people the chance to experiment, get additional skills. The Next Generation GP program, giving people leadership opportunities, all those things can also help you when you're making your choices about careers. And there's plenty of that going on in general practice, which is great, really, especially early in your career. But also career support, that also helps you with the career choices things, mentorship, but also, trainers and tutors. So that's a sort of slide that like some of the juggling for career choices. But I hope it feels positive, because most of that for GP certainly is already up and running. Oops, okay, so I'm ahead. Sorry. So when people then say, well, why would I actually get involved with academic activities? The commonest reason is you have to get the qualification. The second reason is because you choose to. You want to learn more. I'm sorry, the screen is out of sync with what I'm looking at, so if I'm reading a stage behind, bear with me. And this is, again, when bright people sort of like, I really want to understand why we're doing it like that, and how we're, Claire, sort of, why do we have this in the bag here, and that's not what I was trained to do. So things about actually analysing what's led to what, taking a deeper interest or understanding in something that matters to you. So that's another way of making your mark. If you go off and you do a course in X or Y or Z, prison health, commissioning, service development, you're bringing new understanding back because it matters to you, but it also will help you to deliver for the practice. To undertake a new role, so GPs have to, for example, do a PG cert as part of becoming a trainer. And then again, having, that status sometimes gives people, oh, Amanda did a master's in X, so she knows about that stuff. So let's go to her because she's done that hard academic work to really get the knowledge base. And the other thing is, if you like using your brain, it actually, it's different from doing a working day in the practice. It's sitting back, it's reading, it's absorbing data, it's bringing a product. If you're involved in a research project or doing a doctorate or a thesis, it can take, a year, 2 years. So it's a different timeline. And what I find really nice about having had that side to my life is that it is a completely different way of thinking, but the two relate to each other, which is also great. So where does advocacy sit in with this? How, if you want to make your mark, how do academic skills help you? And I'm going to talk about this. We talk micro, meso, macro. That's the academic words, but it's like things for yourself, things for the local level, or things at a system level, because the skills are similar, but actually the way you work is a little bit different. So let's pretend you are actually trying to get a change in role. You're trying to get a promotion towards something. You want to get employed as X or Y or Z. An example of working with others would be making sure that, I want to make sure that people who want to have an academic opportunity can get that during their postgraduate training. Claire was talking about, the efforts towards 5 years training. We'd like, ideally, for everybody in GP training to be able to take some time doing those sort of academic components that would help them to then use those skills in practice. At the moment, we have a QI project, but it's fairly busy. That's a start. Be nice if you had a bit more time to embed that way of working in your careers before you have to take it to the next stage. And then the third one is the sort of local changes you might want to make. So this was what took me into academic stuff. You know, I was really not very impressed with the undergraduate education that I'd had in terms of them becoming a GP. It was very science, it was very lab-based, it was very hospital-based. We had 1 week in general practice, and as my nephrology personal tutor told me, this will teach you how not to practice medicine, how. That was a long time ago, but I've remembered it. And when I became a GP, you know, we had students, we were training practice, but I really wanted to change the way the curriculum worked. So that's another thing about, you know, advocating for that, and I'll tell you a bit more about that if you like. But again, you know, the case had to be made. Just me banging on about it didn't work. Me banging on about it to my practice, who agreed with me, wasn't going to change the medical school. I had to be in the medical school, seating at the table, and get myself heard for anything to change. And to be fair, part of getting heard required systems change. So there's me, I've got my doctorate, I'm a lecturer, senior lecturer, I'm a GP, I'm the only GP on the curriculum committee. You know, they're all blah, 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 why would we want to do that? Then the GMC published Tomorrow's Doctors, saying general practice, medical education needs to change, and here's the modernisation plan, and suddenly the dean is my best friend. You know, so I'd been pushing at that door, but finally somebody else opened it. So those sorts of things are all about, you know, making the case, knowing the evidence, having the policy platform, and then working at the change. And relationships, and again, status, definitely comes into that. Because, you know, in another way, if I just come in out of the blue and say, we really need to change the curriculum, why would people listen? Or we really need to change the service. You've got to do a little bit more than that to make the case. And there's a whole literature, colleagues, as well on change management, which is also about making a mark. And, you know, what Claire said about, you know, getting the relationships and persuading people as well as having the evidence at your fingertips. And letting people try things out for themselves. You know, and then they start to get it, and then they think, oh, that's interesting, which is why we do pilot projects, you know. So you're not committing yourselves, guys. Let's just try it out for a couple of months to make it work differently. And if you've done that analysis and you've put the intervention together in the way you'll evaluate it, you know, again, it's working smart, and people can then often try it out effectively, and hey, guess what? It worked. The other thing is systems level. So I've just got an example here. Again, you know, with something that Claire and I have worked on and talked quite a lot about, the well-being and mental health support. And, you know, everybody says, yes, it's necessary, but actually, how are we going to do it? What do we mean by that? What actual service will people access? How will we run it? What will matter to people? That's an academic exercise with a good A, a small a. Because you've got to, you know, there's no point in setting a service up and then find all the workers either can't go to it because it's at the wrong time of day, or won't go to it because they're worried about confidentiality. Bingo. You know, doesn't sound like rocket science, does it? But all those things are about using that analytic and looking at evidence. Who's done it elsewhere? What's worked? What do we know about it, etc. So you may be able to, again, think of others already, and we can discuss that. But they all need this combination of evidence and analysis and skilled presentation. Okay? Right. Just a little slide on full-time academic careers in case anybody is interested. You do have to get a doctorate. That's a threshold thing to then get an appointment. So there are, as I say, you know, if you say, well, fine, tell me how a GP gets that, funding can be an issue. Making the time can be an issue. I remember a colleague of mine you know, when we were doing our doctorates, like, how long were you at your desk after the kids had gone to bed, Amanda, before you finally put your head down? And, you know, because we were doing it in our spare time. But, you know, you can sometimes create that for, you know, you create it to play golf. So, you know, not my thing. But anyway, each to their own. And then once you've got that contract, you will be part of the teaching and the research teams in the university. And that means that as well as your GP job, so I did mine 6 sessions GP and 4/5 for the university when I first got the job there. And I was doing the curriculum work and also applying for research money and then seeing projects through. And it's actually quite a competitive world. You know, you do have to prove yourself. If you don't get grants, the boss isn't very pleased. It's a different structure. So if you are interested, you can find out more about that. But also within it, usually people develop 1 or 2 areas of special interest. So it might be population health, it might be a particular, you know, clinical diabetes or obesity weight management programs, or it might be, you know, professional. So I did a lot of research on education as well as doing some clinical stuff. And why does that get you then more involved with the college? Well, it's often because you become expert in a particular area and people start asking you about, oh, what tips would you give the members? You do a talk and somebody said, that was really good. Take it to conference. Oh, that was really good. Put you on the stage. Oh, can you join our committee? So it kind of, for academics, I think it opens up often national networks and international networks, because often those conferences are cross-country. And so, you know, one thing can lead to another. Right, some pros and cons. I've told you helping us with research helps us get better evidence for primary care and for GP practice. A lot of studies are based in hospital. A lot of studies are single issue. Our patients aren't like that. We have to do the research with the real world, with the real people. Good teachers inspire others and secure a better GP workforce. So we've seen the change as GPs have, in a sense, been more visible and given people real opportunities to see life outside the hospital. More people could think, oh, actually, you know, I might do that job later. Because in the old days, nobody knew what it was involving, so they didn't choose it. I found this part-time academic opportunities have a good fit with being a GP. A lot of the GPs who teach for me in Norwich, in UEA, which is where I work, really love it because, again, it's different. They feel like they're contributing to the next generation. A day a week on campus doing consultation skills or problem-based learning. It's fun, but it's also using their expertise and knowledge to help other people. So it's got that sort of altruistic reward, like helping a patient. You know, you're helping somebody to learn a job that will matter, whether they become a GP or another type of doctor, still, that's fine. And it does increase, you know, generally increases your networks, you know, bigger scope, more contacts, you meet other teachers across the country, blah, blah, blah. So it can be fun. But, as I've already said, just to be fair, a full-time academic career structure is a bit challenging for GPs, funding, not that many jobs, and the competition is high. So, you know, it's not an easy path if you do take that next step into a full-time academic career. And you're working in a university, you know, it's not necessarily the same assumptions as we'd have in the NHS, so you've got to balance both systems. So my story, very briefly, you know, I grew up in peacetime in the beginning of the NHS. So I was born with a brain. My mother had good midwifery care and good care for her complicated pregnancy. Lucky me. Fundamentals of social determinants of health really, really matter. Everybody's a bit rebellious as a teenager, but because of my public education and my physics teacher, it's like, you're bright enough to do medicine. How? Nobody in my world had ever gone to university. My auntie was a teacher. I thought that would be a good job. People were ambitious by then for their daughters, but medicine, really? And it was only because of my physics teacher and that role modelling and pushing me and coaching me that I thought of applying. And I got in 1 in 10 in med school. So it's quite a big jump to the point where you start getting, you know, certificates and awards. But, you know, again, lucky me. And, you know, I went into general practice. I just put my feet under the table. I had my family. But as I said, I was really committed to changing the way that students learned. And that was partly what got me involved. And then somebody said to me, well, start on a master's, because you'll need that knowledge. You'll need that understanding. You'll need that credibility. And I really enjoyed it. And I hadn't been sporty at school, and I wasn't beautiful, but I was brainy. And so that really, oh yes, I used to love doing essays. I used to love reading stuff. So I actually enjoyed the doctoral work, and that took me forward. And again, opportunities. The guy, my professor, was desperate to grow people like me. And he put some funding for me to, you know, get onto the taught bits of the masters, so it wasn't all coming out of my pocket. He was securing the funding to encourage GPs to get those opportunities. And then he was creating a senior lecturer post, you know, because we really need more capacity in the department. And so I, at the point where I could, I applied for that and I got it, and so on. So it's also about what the system offers you. And from there, I, you know, got into the medical school world, and I actually moved from Sheffield to Norwich because we had one of the new medical schools. Now, somebody was talking about Brighton and Sussex earlier, and, you know, we trained at the same time. Oh, yes, it was Joe, wasn't it? Yeah. And, you know, this is our first graduation. So that was really exciting, setting up a new school and taking that forward, and also getting involved with the college and becoming an officer. And it seemed like a natural progression, because once you've made a change in your place, you kind of think, what about the rest of the world? You know, what's happening in the other medical schools? How can I work to champion this, see it forward? And the college, like, we've got national positions. We at the National Advocates, you know, Martin and his escalator pictures, we spend a lot of time using those academic skills to try and make our mark, but also to working across the national networks for change. So that's how I got involved. But the college was always a friend to me, I would say. You know, right from my faculty, I always used it for that additional support, opportunities, CPD, mentorship from older GPs. You know, if you've got a problem in the practice, talk to Stephen, because he's seen all this before. And, you know, how did you manage that one? And blah, blah. And then, you know, latterly, the more formal roles. So just a few resources if you're looking at this later. Obviously, the college, whether it's, you know, for your qualification, for CPD, for professional networks, for professional opportunities. The Society for Academic Primary Care is our research community equivalent that networks across the different medical schools in the UK, and includes primary care researchers as members who are not doctors, because a lot of our colleagues who do the research with us are health economists, psychologists, you know, and that's really valuable. The national GP training structures through Health Education England, or the other countries have got their equivalents, and those people know about, you know, what the local training fellowships are, what the possibilities for additional programme or out-of-programme opportunities if you're interested at that stage, and also the post-qualification CCT training fellowship opportunities in your community. And then there are other bodies that have some academic remit, like NICE, the Medical Research Council, Institute for Health Improvement, and the Health Foundation, to name but a few. And they're international networks, so a lot of our members don't know that the college is a member of something called the World Organisation of Family Doctors, which actually has about 150 member organisations in its network worldwide. So if you're interested in interested in how general practice could help another country. I mean, some people have got family in another place and they know that the system's different, and people there are saying, you know, wow, your curriculum's amazing. You know, how did they do that? How did they get the specialty exam? That's what WONCA, the World Organisation of Family Doctors, is all about. And I think it's great, you know, again, it's another academic opportunity because we have conferences. It's a way of sharing knowledge, but it's also a way of making your mark, because actually that learning between different countries is really important. And we have an international committee in the college here for people, you know, particularly interested in exchanges with other countries. final bit of my story, I first wanted to be a GP after I'd spent a summer in West Africa as a medical student. I was doing volunteer work. I was so shocked about, I really hadn't understood, I'd read about things, but when you go to a country and you see what it's like for people where the clinic is 40 miles away and anyway I can't afford to go, even though my leg is macerated or I've got a fungating tumour in my breast. I can't do it. I've got to feed the family. And that came out and I was thinking, I really want to get upstream of this. I really want to work somewhere where you can diagnose early and prevent stuff and again, advocate for that. And so the national networks and international networks, I think also are places that people can make their mark very early on, simply by learning from each other and, what works in that country that we're not doing so well with here. What can we help you to learn from? And it's a reciprocal opportunity. So exchange programs, internships, university, online. I've got people mentoring people in Sudan through an online mentorship. That's pretty smart. So all good. Right, and talk to local colleagues, and that's another place you can draw down resources. So thank you very much. There are people all over the world like you, interested in general practice, doing general practice, advocating for general practice, advocating for their communities, advocating for the patient's health. That's the real driver, isn't it? And what can make a difference, and bringing together the evidence to really move that thinking forward. So that's enough front of desk. I'll come down and we can discuss. Is that all right?
So we've had one question online from Sham, who says, generally, are there a lot of funded opportunities for formal academic qualifications? So you've mentioned that a little bit, but maybe specifically kind of starting out.
I think the answer is generally not. Margaret might want to comment as well. So certainly where I work, the number of masters or postdocs, PhDs and so on you can do are large, but most of it will be you paying out of your pocket. Now, to be fair, as GPs, we usually earn quite a reasonable salary. And so if you think, well, I think 2,000 a year to do that, is fine or whatever. But the number of funded masters or funded PhDs compared to the number of people who might like to do them is low. Do you think, Margaret?
I think I'm going to bring you back to Amanda's point about speaking to local colleagues, because it always amazes me as to what's actually out there that we have no idea about. So, like, for instance, recently I spoke to some GP trainees who literally look, as Claire said, look at the jobs that are out there and have come up with fellowships. So NHS England have a number of leadership fellowships, and where they have opportunities to do degrees, whether it's a postgrad certificate, diploma, or a master's, and it's in anything from sustainability to equality in practice. The chap that we had shadowing us this week he was a cancer lead, and so they are out there. And even when you qualify, we have something called clinical commissioning groups, CCGs, who are now evolving into ICSs. There's lots of opportunities there because we're now engaging more with the research sector and voluntary sector and Health Education England. There are paid opportunities. I've just done a postgraduate certificate, fully funded, for genomics in medicine, because I think that's something that's going to evolve over the next few years, particularly with the onset of COVID and how we detect new variants. And, I'm thinking about the masters, but it's how to, again, we talked about the juggle struggle, how we're going to do it all. But yes, they are there, but it's just about speaking to local colleagues.
Yeah, thanks, Margaret. And it's also something, again, we're campaigning for. So through the SAPC, we're just about to do another national survey to try and get a bigger picture, because it's all right me fighting my patch and saying, yay, the training hub's given us 6 new fellowships for this year, but it's not very stable, and I don't know whether the medical school down the road's got 5 times as many as me or only half of that. So, again, I don't think that's unique perhaps to general practice. I think a lot of the hospital specialties may say the same, that the number of structured opportunities to undertake academic opportunities are few, but I think we're a much bigger population overall, 50+% of the workforce, So I think the ratio of academic to the number of people who might like to do them is not good enough. So sorry, Sham, but anyway, let's speak the truth. Anybody else got comments or questions?
Sure, my name's Sylvia. I'm a fifth-year medical student at UCL, just across the road. Thank you for your talk. My question alludes to, at medical school, academic medicine, not just in GP generally, is perceived as something you need to kind of get your foot in very early on, at least as medical students, get involved, do those presentations, go to conferences, etc. So would you say that you are potentially kind of on the back foot, especially given the competitive nature of, full-time academic GP roles, if it's not something you have your foot in early on?
Thank you, Sylvia. That's really interesting, because I think the answer is not necessarily a problem. So I agree. You'll see in a good medical school, we're keen to get people who want to do intercalated degrees to do them, again, making the funding opportunities, making the space, trying to increase the capacity. I'm trying to get more people to do them with us in population health and primary care, rather than, again, in the lab or whatever, no disrespect, but, to make sure that the spread reflects the modern research endeavour in the modern departments. And if you get a bright student who's already, got their publications and intent on, getting their masters under their belt during their formal training by doing an academic training scheme, of which there are usually a few in each region as you apply, great. And to be fair, if they carry on like that, they probably will have the CV to be a lecturer by the time they're in their late 20s. But you can also do it later, because, as I say, life, God willing, is long. And I did that, exactly that. I started in my mid-30s. I've had, 40 years in general practice. I get my life membership next month, Evie. That's lovely, isn't it? And, at the same time, the academic bit definitely didn't start till I was 7 or 8 years in. So I think it's not too late. But, and so the back foot, I would say no. But somebody may get an academic appointment early in the year because they started earlier. Fair enough.
So it's really inspiring to see the Wonka organisation, which I wasn't kind of aware of before, which you mentioned previously as well. So thank you for informing us about that. How has that helped us to shape our practice and thereby also shaping international practice? Thank you.
So I think it's the mechanism of sharing expertise and experiences, whether that be, so the college historically actually was sort of using the efforts and energies that it had put into creating RCGP to then say to other countries, you don't have to start from scratch. Here's one we prepared earlier, but what you will need to do is adapt it to your situation, your curriculum, your population's need, and that was called RCGP International. And then another part of our international section was, helping faculty. So sometimes a country would say, you've already got the specialty in your place, Amanda, please, can you come and help us in Myanmar to, develop the faculty, develop the curriculum, and to understand, specialty assessment, and help us also in that way to come up perhaps to where other specialties in our country are. So sharing expertise, we do that at Wonka Conference. We do it just like the college through special interest groups. I got involved with it partly through my academic activity. So as I started to go to conferences, I was meeting other people, but also I joined their women in general practice group, special interest group, gender and careers. And through that, I was talking to women all around the world all the time about, being women in GPs and helping. I mean, again, no disrespect, but the, evidence was that the guys get in and stay in and earn the money. And many women in general practice were finding that they couldn't fulfill their potential in their specialty because the working conditions and the support for them as dual role in caring were adverse. So lots of discussions, lots of advocacy to be done, and consciousness raising. And I must say again that, you know, also when you look at health systems and you understand that literature, you know, then you can help practitioners to understand it too. So a lot of GPs, you know, don't have some of the knowledge that I've got as an academic over time. It's not just being in a different country. It's not been, you know, what they've been able to concentrate on. So they can see the problems, but they don't know what's better. And so the Wonka networks also enable us to share some of that with people who do have expertise. And the final part of it is we advocate to WHO. Now, talking of making your mark, the World Health Organization, they like evidence. They like, you know, technical advice. If you go in there, you know, just because you believe it, it doesn't make it true. And so Wonka has a direct registered non-state actor status with WHO. Our college has got a memorandum of understanding with WHO, same reason. So those are some of the examples. As I said earlier, the Junior International Committee, there's a regional young doctors movement in each of the world regions through Wonka. Our one for Europe is called Vasco da Gama at the moment, although they're thinking of having a name change. And, you know, people network, their students can join. You know, if you're active, you can join, can't you, in the network anyway. And people, again, you know, I think it's really helping people at your stage to understand things I hadn't understood about what a good health system, you know, should look like. And WHO's, the Declaration of Astana, at which I was present, universal health coverage using comprehensive primary health care, which is accessible, affordable, acceptable to the patient, of good enough quality to deliver its goals, and integrates care over time. Now, what does that sound like to you? It sounds like good general practice to me. So, you know, that's some of the role of Wonka, but our college is very active in that. And we actually have the European conference in June we're hosting in London for Wonka as a whole. So not too late to register.
And final question online from Rumby. And they're asking about tips on becoming a better academic writer. So 2 top tips maybe, and then we can finish.
Okay, well, one is we always have a workshop on that at Wonka, writing. Second is do something with a local medical school or a group and practice writing. And again, this doesn't have to be based on only research data. It could be trying to write a piece about your practice and how to work with the local community, or it could be about a project that you did. The college has a journal for trainees called Innovate. So, you know, you can see articles, read some articles, think about whether they're well written, think about why you liked that article more than that article. It might be because it spoke to something in your heart, but it might be because it was better written. So I think practice makes perfect, Roni. Do it in a context that you're interested in, that might, you know, work for you or your peers or wherever the particular setting is that you might want to write for, but also read stuff and analyze it. Read resources on how to write for publication. Come to a workshop. You know, it's a standard method, isn't it? I think, I read, I reflect, I discuss, I get some tuition, I give it a try. That's 6 top tips. Is that okay? All right, well, thank you very much. Look forward, I'll be around for the rest of the day, so happy to talk individually, but hope that was useful, and good luck with your next stages. Thank you so much.